72 hours. That is all the time insurance companies will have to say yes or no when you're lying in a hospital bed waiting for a critical procedure. 7 days for everything else sounds reasonable, right? Unless you know what happened to Margaret. Margaret was 74 years old, living alone in a little ranch house outside Phoenix. She'd been on a Medicare Advantage plan for 6 years because the premium was $0, and it came with a dental benefit and a free gym membership. Seemed like a smart choice. Her daughter had helped her pick it during open enrollment. The commercial on television looked great. Friendly people, no hidden fees, all the coverage you need. Then her hips started going, not all at once, just a slow, grinding ache that got worse every month. The doctor said she needed a replacement, not an emergency, not a trauma case, just the kind of thing that makes it hard to sleep, hard to walk the dog, hard to get out of a chair without wincing and grabbing for the armrest. So her surgeon submitted the prior authorization request. Standard procedure: Form A, Form B, clinical notes, imaging reports, everything the insurance company asked for, and then they waited. Week 1, nothing. Week 2, Margaret called the insurance company herself, sat on hold for 43 minutes, finally got a representative who said the request was under review. Week 3, she called again. Different representative. This one said they needed more records. What records? The same records already submitted. Week 4, the doctor's office resent everything. Week 5, nothing. By week 6, Margaret was using a cane. She'd never used a cane in her life. It made her feel old, which made her angry, which then made her sad, because she knew she shouldn't have to feel old just because she needed a surgery that millions of people get every year. And by week 8, she'd fallen in the bathroom. Nothing broken, but her daughter flew in from out of state. By week 10, the denial letter arrived, certified mail. 3 paragraphs. Reason: not medically necessary. Her doctor was furious. He'd done this surgery hundreds of times. He called the insurance company himself and was told the reviewing physician, someone Margaret had never met, never spoken to, never seen, had determined that conservative management hadn't been exhausted. Even though Margaret had been doing physical therapy for 8 months, even though she was on anti-inflammatory medication, even though she couldn't walk half a block without stopping, he was livid. So he wrote an appeal, a detailed 4-page letter with citations to clinical guidelines and a personal note. This patient needs this surgery. I am her treating physician. I know her case better than anyone reviewing a file. That appeal took another 6 weeks to process. By the time the procedure was finally approved, Margaret had been in pain for over 4 months. She'd lost muscle strength from being sedentary. Her recovery was harder than it should have been. Her daughter had burned through 12 days of unpaid leave. The surgery itself cost the insurance company more money in the long run because the delay had made the case more complicated. And here is the part that makes you want to throw the denial letter across the room. A federal review later found that many of these denials never should have happened in the first place. The government looked at some of these prior authorization decisions and said, actually, these patients did meet Medicare's own coverage rules. The insurance companies just denied them anyway. That is not a bug in the system. That is the system working exactly the way it was designed to work. Let me explain exactly what we're talking about. There are approximately 33 million Americans enrolled in Medicare Advantage plans right now. That is more than half of all Medicare beneficiaries. The program has grown explosively, fueled by aggressive marketing and $0 premium plans that bundle dental, vision, and hearing coverage. It looks like a better deal. It sounds like a better deal. But here is the catch. Of those 33 million people, approximately 99% of them are subject to prior authorization for at least some services. That number comes directly from a government report, 99%. Essentially, every single person on a Medicare Advantage plan must get pre-approval for something before they can receive care. For some plans, that list is extensive. Hospital stays, skilled nursing facility admissions, home health care, chemotherapy, durable medical equipment like wheelchairs and oxygen concentrators, advanced imaging like MRIs and CT scans, some outpatient surgeries, even certain types of physical therapy. In 2024 alone, tens of millions of prior authorization requests were submitted. The administrative burden on doctors is staggering. Some large physician groups employ full-time staff whose only job is to fill out prior authorization paperwork. That is time that could be spent on patient care, spent on actually treating people. Instead, it is spent on justifying to an insurance company why a patient needs the care their doctor already said they need, and somewhere along the line, the denial rate jumped by 56%. That is not a gradual increase. That is a spike. Something changed. Maybe plans got more aggressive about cost cutting. Maybe the automated review systems got more sophisticated. Whatever the reason, real people were being told no for procedures their doctors said were necessary. And here is what makes prior authorization so insidious. It actually started as a reasonable idea to control costs. But insurance companies realized that prior authorization is not just a cost control tool. It is a denial tool. Every time they say no, they do not pay. And the more hoops they make you jump through, the more people give up. A significant percentage of denied claims are never appealed. Sometimes because the patient does not know their rights, sometimes because they are too sick to fight. The insurance companies bank on that, and often they are right. This is the world we have been living in. But in April of 2026, something actually changed, something real. Let me run through the new rules one by one, because this is information you need to have in your back pocket. These rules come from the Centers for Medicare and Medicaid Services, CMS, and they went into effect as part of the 2026 Medicare policy updates. Some of them are genuinely game-changing if you know how to use them. Rule number 1. And the most immediately impactful hard deadlines. If you need urgent care, and the definition of urgent is anything where a delay could seriously jeopardize your life, your health, or your ability to regain maximum function, the insurance company now has to respond within 72 hours. That is 3 calendar days. That includes weekends. If you are in the hospital waiting for a procedure to be approved, and the insurance company drags its feet past 72 hours without a decision, they are violating the rules. For non-urgent requests, routine scheduled procedures, ongoing treatments, elective surgeries, the deadline is 7 calendar days, 1 week. If the insurance company cannot make up its mind in a week, the request is supposed to be escalated and expedited automatically. Compare this to the old system. Under the old rules, there was effectively no enforceable deadline. Some plans had internal targets, but they were not enforced by CMS in any meaningful way. People waited weeks. Margaret waited 10 weeks. Under these new rules, that kind of delay is a compliance violation. That is a big deal. But here is the catch, and I want to be straight with you. The deadlines apply to the insurance company's decision, not to the process of getting the doctor to submit the paperwork. If your doctor's office takes 2 weeks to send in the prior authorization form, the 72-hour or 7-day clock hasn't started yet. The clock starts when the insurance company receives a complete request. So the bottleneck can still be at your provider's office. That is something to watch for. Ask your doctor, did you submit the prior authorization? When did you submit it? Do you have a confirmation number? Follow up. Stay on top of it. Rule number 2. Once they approve something, they cannot unapprove it. This has been devastating for patients. You have probably heard stories or lived through one, where a treatment gets approved, you start it, and then a letter shows up saying, actually, we have reconsidered, and we are not covering the rest. This goes by different names: concurrent denial, retrospective denial, reversed approval. The effect is the same. You are in the middle of a treatment, and now you owe thousands of dollars for care that was previously approved. Imagine starting chemotherapy. You lose your hair, you feel sick, you drag yourself back for round 2, and the billing office tells you the insurance company reversed the approval for the remaining cycles. You owe the hospital $40,000 that happened regularly. Or imagine recovering from a stroke in a skilled nursing facility. The plan approved 30 days. You are on day 12. Finally making progress, and a letter says your stay is no longer medically necessary and you have 48 hours to leave. That happened too. The new rule says once a service is approved, the plan must honor that decision. The only exceptions are fraud or a clear administrative error. This provides stability for patients undergoing long-term treatment. It is a major win. Rule number 3. Mental health care must be treated the same as physical health care. This has been a quiet inequity in the system for years. Insurance companies have imposed stricter prior authorization requirements on mental health services than on physical health services, even though federal law, the Mental Health Parity and Addiction Equity Act, has technically required equal treatment since 2008. But enforcement has been weak, and Medicare Advantage plans have found ways around it. Want to see a cardiologist for chest pain? That probably does not require prior authorization. Want to see a psychiatrist for depression? That might require a separate referral, a prior authorization form, a treatment plan review, and a 2-week wait. Want to check into a residential program for substance use disorder? Good luck. The hoops are enormous. The new rules say no more. Mental health services and substance use disorder services must be held to the same standards as any other medical service. If your plan allows you to see a specialist without prior authorization, then you can see a mental health specialist without prior authorization. If outpatient physical therapy does not require pre-approval, then outpatient therapy for depression does not require pre-approval either. This is a significant step toward equitable access to care. Rule number 4, transparency. And this one might be the most important long-term change because it shifts the balance of information starting in 2026. Every Medicare Advantage plan has to publicly report their prior authorization data every year. They have to tell you exactly how many requests they received, how many they approved, how many they denied, how many were appealed, and how many appeals they upheld. For the first time ever, you will be able to look at two plans side by side and say, Plan A denies 15% of prior authorization requests, and Plan B denies 3%. I think I will go with Plan B. That information has been hidden for decades. Insurance companies fought to keep it hidden. Now it is public, and public shame works. When an insurance company has to admit they deny 30% of chemotherapy requests while their competitor only denies 8%, that creates pressure. That changes boardroom behavior more effectively than 1,000 pages of regulatory text. Rule number 5, tighter alignment with traditional Medicare standards. Some of the most egregious denials happen when a Medicare Advantage plan uses its own internal coverage criteria that are stricter than what traditional Medicare uses. The plan might say, our internal guidelines say we do not cover this particular medication for this indication, even though Medicare's own national coverage determination says it is standard of care. Or the plan might define medical necessity in a way that excludes conditions that Medicare clearly covers. The new rules force plans to align their coverage criteria more closely with traditional Medicare standards. That means fewer denials based on fine print that nobody ever read and nobody ever agreed to. It means more consistency across the system. It means fewer surprises when you show up for care. Rule number 6, technology improvements. CMS is rolling out what they call the interoperability rule, which requires electronic prior authorization systems. Right now, a lot of prior authorization is still done by fax. Fax in 2026. Your doctor's office literally puts a piece of paper into a machine that was invented in 1843, sends it over a phone line, and a claims processor looks at it whenever they get around to it. That is not efficient. That is not modern. That is an anachronism that causes real harm. The new digital systems are supposed to automate and streamline the process. They are designed to improve communication between providers and insurers so that data can be exchanged electronically, decisions can be made faster, and the whole thing becomes less of a nightmare for everyone involved. It will not be fully implemented until 2027, so we are in a transition period. But the framework is being put in place now, and early improvements should start reducing delays even before the full rollout. Now, I want to be completely honest with you. These rules are good. They are genuinely good. They represent the most significant reform to prior authorization in Medicare Advantage in years. But they are not a cure. All prior authorization is still here. It is not going away. And there are some things these new rules do not address. One is the rise of automated or algorithmic denials. Some insurance companies have started using computer programs to review and deny prior authorization requests without any human involvement. You submit the request, an algorithm scans it, checks a few boxes, and spits out a denial letter. No doctor reviewed your file. No nurse looked at your clinical history. A piece of software decided you do not deserve the care your physician prescribed. The new rules do not fully address this. The 72-hour and 7-day timelines apply, but if a computer can generate a denial in 30 seconds, those timelines do not help much. You still have to fight the denial. You still have to appeal. The convenience of the timeline is meaningless when the denial itself is instant. Another issue is documentation requirements. Insurance companies deny requests all the time because of missing paperwork or technicalities. We need a prior authorization form, not a standard referral form. Your doctor used the wrong billing code. The clinical notes do not include the date of onset. The prior authorization number is missing from page 3, paragraph 2. It is an endless game of bureaucratic gotcha. The new rules do not fix this. You still need to make sure your doctor's office is on top of their paperwork, that they are using the right forms, that they are coding everything correctly. And there is the sheer volume problem. Even with faster timelines, the number of prior authorization requests submitted every year is enormous, tens of millions. The administrative infrastructure is overloaded. Speeding up the timeline helps reduce the suffering of individuals waiting for decisions, but it does not solve the fundamental structural problem, which is that an insurance company stands between you and your doctor's recommended treatment. Prior authorization is a gatekeeping function by design, and these rules open the gate a little wider, but they do not remove it entirely. There is also the question of enforcement. These rules are only as strong as the agency that enforces them. CMS can levy fines and penalties against non-compliant plans, but the history of Medicare Advantage oversight is mixed. Some plans have been cited for violations year after year with minimal consequences. Whether CMS steps up enforcement alongside these new rules remains to be seen. So here is what you need to do, practically right now today. First, know exactly what your plan requires. Not all Medicare Advantage plans have the same prior authorization rules. Some plans require pre-approval for nearly everything. Some require it only for a short list of high-cost items. The difference between a good plan and a bad plan can be enormous. Call your plan, ask them directly. Please send me a complete list of all services that require prior authorization under my plan. Ask them to put it in writing. Or better yet, pull out your evidence of coverage document. That is the big booklet they mail you every year. It looks boring. It is boring. But buried in there is the list of services that require prior authorization. Highlight them. Know them. Second, when your doctor tells you that you need a procedure or a test, ask them directly, does this require prior authorization? If the answer is yes, ask who is handling it. Is it the doctor's office? Is there a dedicated prior authorization department? When do they plan to submit it? Can you get a confirmation number once it is submitted? Do not assume the paperwork is being done. Sometimes things fall through the cracks. Medical offices are busy and understaffed. A quick phone call can save you weeks of waiting. Third, know your appeal rights. Every denial letter you receive must include instructions on how to appeal. Do not throw that letter in a drawer. Do not assume the denial is correct. The data shows that many denied claims are eventually approved on appeal. The insurance companies are counting on you not bothering. Prove them wrong. You usually have a limited window, often 60 days from the date of the denial, to file your first level appeal. Mark your calendar the day you get the denial. Give yourself a deadline. Get your doctor involved. A letter from your treating physician explaining why the procedure is medically necessary carries significant weight in the appeals process. And if the first appeal is denied, you have the right to request an independent external review. That review is conducted by an organization that has no connection to your insurance company. The overturn rate for external reviews is surprisingly high. Fourth, and this is entirely new because of the 2026 rules, use the transparency data when open enrollment comes around and you are comparing plans. Look at their prior authorization denial rates. That information will be publicly available for the first time. A plan with a $0 premium and a great dental benefit might look perfect on paper. But if their denial rate is 25%, that premium saving could cost you your health. Do not compare only price and perks. Compare denial rates, compare appeal overturn rates. The plan that denies less care is the plan that will take better care of you. Fifth, if you are considering switching between Original Medicare and Medicare Advantage, or between different Advantage plans, pay close attention to prior authorization requirements in the plan's summary of benefits. Some plans brag about how easy their approval process is. Some are conspicuously silent on the topic. Read between the lines. If a plan does not provide clear information about their prior authorization process, that is a red flag. Sixth, and this is something that shocks me how few people know, you are not stuck forever. If you chose a Medicare Advantage plan and it is not working for you, you have options. During the Medicare Advantage open enrollment period, which runs from January 1st through March 31st each year, you can switch to a different Advantage plan or go back to Original Medicare. And if you are in your first 12 months on a Medicare Advantage plan, you have what is called a trial, right? You can drop the plan and return to Original Medicare without penalty. Most people do not know about the trial, right? It is one of the most valuable escape hatches in the entire Medicare system. Let me step back now and talk about the bigger picture, because I think context matters here. The reason I spend so much time on Medicare Advantage is simple. It is the most aggressively marketed healthcare product in America. You see the commercials everywhere. Joe Namath telling you how great his plan is. Jimmy Walker saying everything is die. No might. William Shatner being William Shatner. They make it sound like an all-inclusive vacation package. Free gym memberships, dental coverage, eyeglass allowances, maybe even a transportation benefit to get you to your appointments. And in many ways, it is a legitimate product that works well for certain people in certain situations. But the problem is that the warm, fuzzy sales pitch comes from the same companies that are denying your care behind the scenes, the same company that runs the cheerful commercial with the golden retriever and the smiling seniors playing pickleball is the same company that employs the claims processors who denied Margaret's hip replacement and made her wait 10 weeks. That is not an accident. That is a business model. Sell you the dream on television for 30 seconds, then deny you the care behind a desk for 30 days. The premium is low, so you sign up. The denials are high, so they make money. That is the math. The 56% increase in prior authorization denial rates tells you everything you need to know about where this system was heading before the new rules kicked in. It was heading in one direction, and that direction was bad for patients. The 2026 rules are a course correction, the most significant one we have seen in years. But they are not the finish line. They are a step in the right direction. There will need to be more steps. And here is what I want you to take away from all of this. The healthcare system, and particularly the Medicare Advantage system, is not designed to be your friend. It is designed to manage costs. Sometimes it manages them in ways that line up with your interests. Sometimes it manages them in ways that harm you. The new rules put some guardrails up, and that is genuine progress that advocates and regulators should be commended for. But the ultimate responsibility still rests with you to understand your own coverage, to advocate for yourself and your loved ones, and to push back when you are told no. If you or someone you love is on a Medicare Advantage plan, have a conversation this week. Ask what requires prior authorization. Find out how to submit an appeal if you need to. Write down the phone numbers for your plan's customer service line and their appeals department. Put them somewhere you can find them. Because the worst possible time to learn how to fight a denial is when you are already sick, already stressed, and already running out of time. The system changed in April of 2026. Some of those changes are real and meaningful. Some are still unfolding as the technology rollout continues into 2027. But one thing has not changed and will never change. Nobody is going to care about your health as much as you do. Not the insurance company, not the government, not the celebrity in the commercial smiling at you from your television screen. You are your own best advocate. And now you have better tools and better rules to help you do that job. That is all for today. Thank you for watching.